Well, again, this patient in 2016, we're lucky in that we have a number of choices. Many of them have only been studied really in the first or second line metastatic setting. Many of them have only been studied in combination with a type 2 aromatase inhibitor. For the case of the CDK inhibitors, that's letrozole or fulvestrant. That's our other targeted agent that we can combine with endocrine agents. We really don't have a lot of data about the use of the CDK inhibitors past the second line, whereas with the use of everolimus, we've studied that in patients who have progressed on a type 2 aromatase inhibitor. That's the kind of the eligibility criteria for the BOLERO-2 study. So I think both in terms of data-driven decision-making, meaning we have data in the setting, and also in just very practical, like what targeted agent can I get covered in combination with anti-estrogen therapy, I think everolimus is a good choice. If you really were worried about her liver lesions or she really was having bumps in her liver function test, I think it's also appropriate to consider capecitabine, which is an oral chemotherapeutic agent, but I don't think there's any harm in at least trying an 8-week course of a targeted agent and anti-estrogen therapy. I just keep a close eye on her. And given that she's 3 years out from her initial diagnosis and is still having minimal symptoms, I think it's very appropriate to choose an anti-estrogen strategy. And I should mention that, encouraging patients to go on a clinical trial at this point is really important too, because a lot of the anti-estrogen trials with targeted agents will not allow patients who have received chemotherapy in the metastatic setting. So it's also a very good time point to be thinking about clinical trials. It's also, at least in my practice, it's a time where I'm thinking about repeating a biopsy to repeat the estrogen receptor and the HER2 status. And it's also a good time to be thinking about, some of the genomic assays for metastatic disease that we can employ.